Hi everyone, and welcome to ABC's Anesthesia. And hey, today we've got Kim, who's coming along to be examined again, which is just such a great experience for people to be able to watch this. I know it can be confronting, so really well done, Kim, for just being part of this. Hope it's really useful. Kim, tell us a bit about yourself.
Thanks, Leo. So I'm a fourth-year trainee in Sydney at a major centre here. I got an invite to the Viva just recently, so the Viva preparation is ramping up rapidly. And I'm keen to get involved, get as much experience as I can.
Do you find the Viva game seems like, we just like everyone in this position, we've been doing anesthetics for 4, 5, maybe even 6 years. And what do you find is so different about the Viva compared to, real life and the practice you've already done?
So I've mentioned this to other people. I've never actually described an anesthetic in depth. I've never really articulated all the thoughts in my head. A lot of things that you would do are done kind of subconsciously or without articulating certain aspects to it. And obviously in a room in a Viva, you can't show the people what you're doing. You have to describe what you're doing, and that's certainly a challenge. And that's, I guess, where a lot of the practice comes in, just to state the things that you would do from whatever seems the most obvious.
Yeah. And just to reflect back on every country will have their examination standardization process. What I really love about the ANSCA Viva, it does test a lot of things that, it's about communicating and saying things in a certain way. And this is not always absolutely transparent from the question itself, and all examiners examine differently. But I like that in the sense that is real world. Like sometimes you're in theater and the surgeon it will be different, will communicate differently, maybe a nurse will as well. And your ability to communicate things and make difficult decisions, it feels like a real life experience, even though it's under the pressure of an exam. So
yeah, I agree.
Yeah, beautiful. So what we'll do, I'll give you 2 minutes reading time, and I'll put this Viva stem up. And like with all things in this Viva, I'll read the question first, because that frames the way you think about things. Actually, for everyone listening, I might actually read this out slowly. You're taking over a functional endoscopic sinus surgery, or FESS, case from a colleague in a private hospital because the morning list is running over time and the colleague needs to leave. The handover given is that the patient is a 50-year-old man undergoing a FESS with mechanical positive pressure ventilation using a flexible laryngeal mask airway. Anesthesia is being maintained with TCI, or target controlled infusion, of propofol and remifentanil. Observations have been stable with a targeted mean arterial pressure, or MAP, of 65 after the surgeon requested hypotensive anesthesia. The medical past history is obstructive sleep apnea on nocturnal CPAP, hypotension with a preoperative BP of 130/63 and a MAP of 85 millimeters mercury. He's a smoker, 10 cigarettes a day with a 20-pack year history. He's on amlodipine, 5 milligrams once daily. There's no allergies, drug allergies. Observations are heart rate 70, blood pressure 100/47, MAP of 65, SATs 98%, FiO2 40%, temperature 36.5 degrees, weight 90 kilos, height 177 centimeters with a BMI of 29. What are your key considerations when administering hypotensive anesthesia for this patient? And everyone who's watching or listening on the podcast or watching on YouTube, please just pause the video, because we'll probably cut out this length of 2 minutes, but that's what you normally get. But let's get started. 2 minutes starting now.
Okay, so thanks, Leo. Kind of globally, what we got here is an ASA 2, potentially 3 gentlemen. It's a crowded airway procedure. We're in a private facility, and it sounds like it's in ours. The goal with hypotensive anesthesia is to provide a bloodless feel, but we've got to balance it against the risks of hyperperfusion to brain, kidney, and the heart. And this guy's got established hypertension from the history. So his autoregulatory physiology may be impaired. So my risk tolerance kind of needs to take in a bit more information. So during that handover with the other, we need to find out more about this guy's hypertension and his OSA and the stability and severity of that disease. I'd like to know whether he's taking his amlodipine this morning. I'd like to know if he has any other conditions of a vascular nature, like cerebrovascular disease, coronary artery disease, maybe chronic kidney disease, because all of this will influence my my target. I think with this guy, I'd be aiming for a blood pressure no lower than minus 20% his baseline. So if his baseline map's 85, I would say I'd be setting a target, not exactly a hard target, but a target of 70 millimeters of mercury before I start optimizing other things that can improve surgical access for the surgeon.
Yeah, very good. Now, so you mentioned the reason for hypotensive anesthesia. So what commonly is a method of doing hypotensive anesthesia, and what again was the reason or indication?
Yeah. So the reason is to provide a field for the surgeon that has as little bleeding as possible, so they have good surgical conditions. That comes with benefits in so that there's less bleeding and the operative time is shorter. There are a variety of ways to provide a bloodless field. Hypotensive anesthesia is one of them. We can also increase venous drainage from the head by elevating the head of the bed, reducing positive pressure ventilation, taping, not tying. With the hypotensive anesthesia, the agents often used, and we can see it in this stem here, is like a remifentanil infusion to lower the heart rate, lower the vascular tone, to provide conditions where there's a limitation to the blood going to that field and an easy access of blood out of that field.
Yeah, good. So what would you run normally if you were to try to do this kind of anesthetic?
Yeah, I'd run a remifentanil infusion using a Minto TCI, titrating the concentration to the desired effect.
And what numbers would you range it between, do you reckon?
Anywhere from 4 to 6 nanograms per ml.
And you're running propofol as well, or Volta?
Absolutely, no, I'd run propofol.
Yeah, okay. Is there good evidence for this?
Look, I'm not sure of the exact evidence. I know it's fairly standard practice to run a bloodless field hypotensive anesthetic. We have good evidence that profound hypertension has bad effects on patients in terms of cardiac, coronary, cerebral, renal outcomes. So it has to be done judiciously and with some quite tight patient selection. But as far as in my own practice, I've been asked to achieve bloodless anesthesia or bloodless field anesthesia with hypertension quite often. So it is certainly been the wheelhouse of a lot of clinicians.
Yeah, okay. And you mentioned some other factors, like patient factors that would make you a bit concerned about this. Let's say you had no investigations and this patient wasn't really worked up from that point of view. What specific symptoms would make you a bit more concerned?
Symptoms. So again, I'd be concerned about the patient who has like unstable coronary artery disease, unstable baseline hypertension, any history of cerebrovascular accidents or TIAs. So the symptoms that we're talking about here would be unexplained orthopnea, palpitations, chest pain, history of focal neurology that may have come and gone or has persisted. Those sorts of vascular underlying symptoms would concern me that might be someone in whom standard hypotensive anesthesia would not be a sound practice.
Yeah, great. What other risk factors would make you concerned with it in the absence of symptoms?
So obesity, type 2 diabetes, established hypertension, established diseases like ischemic heart disease or chronic kidney disease, smokers, people who drink, diagnosed or undiagnosed obstructive sleep apnea. These would all raise my concern and therefore raise my or change my risk tolerance for providing hypotensive anesthesia for a case like this in a patient like that.
You mentioned the 20% from baseline. What makes you choose 20%? Is there evidence for that?
Yeah, so with auto-regulation, within the realms of about 20% on either side, these circulatory beds can provide adequate flow. Outside those ranges, it becomes a little bit tenuous as far as the evidence goes. But that assumes a healthy patient. It assumes a patient who has intact physiology. With someone with established diseases that might change the autoregulatory boundaries, it's hard to know what happens outside 20% or even 30%.
Are we talking about autoregulation where?
So at the level of the brain, at the level of the heart, at the level of the kidneys, in those localized beds.
And what number range is the autoregulatory bed that we're thinking of? Primary?
I don't particularly remember. That's from part 1. 50 to 150 comes to my head in terms of a map number.
Yeah, good. That's a CPP. That's right. That's a CPP, or 60 to 160. So yeah, 50. So this 20% value doesn't really fit into that autoregulation. What do you think? Why are you happy with 20%?
To me, it strikes a balance between providing a degree of hypertension that will certainly improve the surgical access for the surgeon, while maintaining a perfusing pressure it's not borderline. It's certainly within the realms of some degree, a margin of safety. And obviously, bloodless field, hypotensive anesthesia is not something you're going to be doing for 3 minutes. It's probably something you're going to do for 30 minutes. So you need that buffer. Otherwise, you might find yourself in a bit of trouble.
You mentioned about the autoregulation of disease states, making that autoregulation maybe not function. Is there anything else that would make it not quite work in the way you might want it to?
Again, I'm drawing from part 1 memory. I wonder if being under anesthesia might alter your regulation. Yeah.
That sounds about right. Now, let's say, the surgeon says, look, there's just too much blood in the field. This is hard to operate. And what you mentioned some other measures. What are all the things that could be done to get blood in the field?
So we can increase the drainage of blood from the head. So elevating the head of the bed, turning off positive pressure ventilation, like putting on ZEEP essentially. If we had a tube tie on, we could change it to a tape if we could get access to the head. The surgeon themselves can apply vasoconstrictor agents. So adrenaline, phenylephrine are commonly used. We could administer something like tranexamic acid to try and increase the coagulation within the body. And that would be my options from a non-specific hypertensive anesthesia point of view.
Again, that sounds pretty fine. Let's say the surgeon really wants you to maybe we've tried everything. What would you say the surgeon said, oh, look, just get the blood pressure down to 60. We just need it lower. What would you say to that?
Yeah. So it's going to be sort of, I guess, a shared decision. I did outline my concerns that this patient may not be able to tolerate that degree of hypertension for any period of time without some degree of injury. But we have a job to be done here. So I need to know what's in front of the surgeon, what degree of blood they have in the field, what is the limitations to their access, and for how long do they think that they would need me to put them, to all this patient's mean arterial pressure to 64 before they have good conditions. I think it's going to be a decision over the drapes, trying to balance the pros and cons of each option.
And if at the end of the day they say, hey, we need 60, and you've had all your discussions, but there's a bit of a lack of insight either direction.
Yeah,
who wins?
Look, I don't think anyone particularly wins.
Decision.
I would be making an argument that I think 60 millimeters of mercury for this guy might be too low to be done safely, and we wouldn't be doing a service to him. So it might be graded. Let's say we bring up 70 to 68 and see where we're at, 68 to 66 and see where we're at, maybe 66 to 64 and see where we're at. But I don't think I want us to go below 65 in this gentleman. I don't think it'd be safe. So it's going to be sort of graded assertiveness, a bit of negotiation with the surgeon. We both want the correct thing for this patient. I want to keep the patient safe from all aspects. The surgeon who's involved in operating this guy's nose needs really good conditions, and it's my job to provide those conditions, but there are certain limitations from time to time.
Yeah, absolutely. So let's say all of that goes ahead, but you're able to maintain a MAP of 65, but suddenly the blood pressure starts dropping. The MAP is now less than 55 and kind of falls a bit dramatically. What do you do?
Okay, so that's concerning. Unexplained hypertension requires vigilance. So I would confirm the reading on the monitor and put a finger on the pulse. I'd call for help. My anesthetic assistant would be useful to be in the room. I'm going to scan the monitor, and I'm going to scan the patient. I'm going to scan the surgical field for any other abnormalities that are present. And I'm going to let the surgeon know, look, we have a degree of hypertension here that I haven't quite got my head around yet.
Okay, great. You do ask the question from the surgeon and say, yeah, look, there's a lot of bleeding. And because you've scanned the field, you check the sucker and it looks like there's like about 500 mils suddenly in there.
Yeah, okay. So I'm going to temporize. I'm going to increase my FiO2 to 100%. I'm going to give a fluid bolus, 500 mils of Hartmann's and half a milligram and 0.5 milligrams of metaraminol. The differentials here, it sounds like this guy is bleeding, so there could be potential for hypovolemia, but I consider other things like this guy being considerably deep under anesthesia with wiggle room to lyse him. Have we had anaphylaxis for any drugs that we've given recently? And I'm trying to work around those additional diagnoses while addressing my main concern, which potentially is hypovolemia. I'm going to speak to the surgeon and get an understanding of how much blood are you looking at? Is it flowing rapidly, or is it just been increasing slowly over the last few minutes? Do you know where it's coming from? And do you have a plan from a local point of view to cease bleeding? I.e., do you have cautery? Do you have topicalization? Are you going to pack any gauze?
Yeah, look, it's a bit of a very vascular bed that they're having trouble controlling locally.
Yeah.
And they need to actually, so at this point, the surgeon says, hey, I need the blood pressure just dropped just temporarily while I find the source of the bleeding and try to cauterize this. What do you say to that?
So it's an interesting question. We've got an acute issue. This isn't necessarily hypotensive anesthesia here. We have uncontrolled bleeding. So in this setting, the kind of goalposts do change. I'd be planning to do my hypotensive attempts at the same time the surgeon is prepared to do whatever they need to do so that we minimize the time of hypertension. So I'm going to optimize everything I can from my end. So FI2 100%, I just talked about tranexamic acid. I'd increase the head of the bed a bit more. I'd actually make sure there's no positive pressure. I'd give another fluid bolus of 500 mils of crystalloid. And from the surgeon's point of view, I'd just ensure that they know that the timer essentially is going to start shortly and I need them to be ready. And I might even give a time limit, like I'm going to give you 90 seconds of that level of hypertension, for which I need you to try and cease the bleeding. And then I'm going to proceed from there and let the surgeon know what's happening now, just so we are on the same page and we're working together.
Yeah, good. They say it's they manage to get the major bleeding area, but let's say there's another area that's still quite vascular. It's going to take 15 minutes for that. What are other things that you could do in the meantime while you're supporting with fluids and vasopressor? Anything else you could be doing?
So I would just go back to basics and optimize all the things that I can. So what is their hemodynamic status of the patient at this time? What is their oxygenation and ventilation at this time? Are they stable or unstable? We've got good access, and I'll send off a venous blood gas. We don't have an arterial line to see what we're doing from an acid-based point of view or ventilation point of view, lactate. It'd be prudent you could send off a fibrotin, which is available in my center, to see if there's any coagulopathic underlying state that we can correct. It doesn't sound like this guy needs urgent blood products, but I'm sure that we have a group and hold in our system so that if we were to call for blood bank to send blood, we would have that available.
Let's say you do all those measures, you actually do put an art line in and you get a venous gas, and it obviously comes back as quite normal because you haven't given all the fluid resusc yet, but it's 110. And all the obs are now stabilized, and you're continuing to run your appropriate hypotensive anesthesia. So everything's settled from that point of view. The surgeons are happy and you are happy. Then you notice that as you're positive pressure ventilating, things aren't quite going that well. Your tidal volumes are a bit lower. Your oxygenation goes from a stable 98 to 90%. What do you do at this point?
Yeah, again, I'm concerned. This is a laryngeal mask and a flexi LMA. So I'm going to assess this patient from a monitoring point of view. So they've gone from 98 to 90%. Mm-hmm. I assume we're still on 100% FiO2. That concerns me. I'd like to see what their ventilation is and look at the capnogram and the waveform, as well as the spirometry to see if there's a leak and the degree of the leak. I'd like to see what our airway pressures are.
All of those are problems for you. The NTLC2 is variable. You're feeling a bit of extra pressure, but occasionally good, occasionally not.
Yep.
I think that's pretty much what you feel.
Again, FiO2 to 100%. My concerns here is, have we got some sort of mechanical problem with this LMA that's no longer functioning well, or is there something happening in the lower airways, like blood clotting the some portion of the airways?
The surgeons say that is a possibility after what's happened.
Okay. I don't like this LMA, if I'm honest. And
Artline, Remy, Propofol, LMA.
Yeah. I don't like it. So I think it would be prudent to establish a secure airway. My concerns here is that we may not be able to oxygenate and ventilate very well through that LMA. And we've had bleeding and we have a poorly seated LMA. I'm wondering and worried about this guy aspirating on blood. So this guy needs a secure airway. It's going to be tricky to achieve. My concerns are that it might be a difficult airway or difficult intubation from an OSA point of view. And this is the patient's history. We've now got soiling of the airway, and we are intraoperative, so it's logistically there's a bit of moving around and discussions that need to be had. Actually,
before you start with your decision, what are all your options for converting this airway?
Okay, so option one, we could take out that flexible LMA and put in a new type of LMA, like a second generation, which will hopefully provide a second seal. The surgeon may not be happy that it's not a flexible LMA. Option two, and I'm not sure if this is possible, but in the context of a practice viva, I wonder if you can intubate down a flexible LMA. Full disclosure, I don't know. And option 3 would be removing the LMA and putting in like an endotracheal tube, which is either a standard tube or a south-facing ray.
Great. Which one do you choose and how do you go about it?
I would go with removal of the initial LMA and replacement of an endotracheal tube, ideally a south-facing ray. But it needs to be planned and prepared for because there are some complexities to this picture.
Mm-hmm.
So I'm going to inform the surgeon that Airway is tenuous and I'm going to intubate, and then I need him or her to step away from the surgical field. I'm going to pull the trace back. We're going to optimize the position of the patient such that they are in a intubating position. I'm going to call for help in the form of my anaesthetic assistant and for a second and need just if there's one available.
There isn't one, but keep going.
Yeah, okay. I'm going to prepare airway equipment. So what I want in this setting, I'm kind of treating this like a bleeding tonsil. What I want is a video laryngoscope, a direct laryngoscope. I want that size 4 AMBU second generation available. I want 2 Yanker suckers, a 7 and an 8 standard and south-facing ray tubes available. Before we manipulate that LMA, I'm going to suction the oropharynx really thoroughly under direct vision to get all any secretions of blood that might be pooling on the LMA. And then we're going to establish neuromuscular blockade with 100 milligrams of rocuronium.
So you do the suction before the neuromuscular blockade?
I don't see a reason why I wouldn't. Look, there's no harm in doing the neuromuscular blockade first and then suctioning, and you might actually improve the conditions.
What do you give? And
in terms of neuromuscular?
Yeah, and any other?
Yeah, I just give 100 milligrams of rocuronium to establish good paralysis in a time-sensitive manner. Then we'll prepare for intubation, which will involve taking out the flexible, putting in your laryngoscope, hopefully getting a good view and passing in an endotracheal tube. Inflate the cuff and get a CO2 trace on the monitor.
Yeah, good. You don't get a CO2 trace back. What do you do?
That is concerning. I'm going to ensure, so I'm going to call for help, make sure my anaesthetic assistant stays in the room. I'm going to scan all the monitors and make sure there's been no other alteration except for the CO2 trace has disappeared. I'm going to go to my machine and ensure that my gas sampling line is connected and going to my endotracheal tube. We're going to put the patient on the bag and see if we can hand ventilate and see what the compliance is and see if we get an end tidal trace there.
What pressure do you have on your bag with hand ventilation?
No, about 10 centimeters of water would be on the end.
Loss of pressure completely.
Okay. Concerning that we are potentially not in the right place. But I'm just quickly going to go and look if there's any obstruction in the tube and listen to the endoscopy of the chest. If we're not passing air, so you're not going to hear anything. Video laryngoscope is going to go back in the mouth. I need to rule out esophageal intubation as the first port of call.
It's not great to see, but it looks like it's going through the cords, but it's crowded in there.
Yeah, okay. This has been a difficult intubation, so not immediately going to remove that tube. At this stage, we are not ventilating this patient, and it looks like there is a tube in the trachea. I'm going to call for help by pressing the arrest button. Quickly scan all the monitor and make sure this patient has an output.
Yeah, they've got a pulse. That's still 95%.
Yep.
And just patient's tachycardic and hypotensive.
Yeah.
So let's say heart rate of 110, blood pressure is 110 systolic.
Okay. So the problem is not output issue. We can't generate pressure to go through the lungs. I'm going to, again, suction the oropharynx, remove that endotracheal tube and re-intubate under video laryngoscopic.
You can get it in again?
Yeah. And inflate the cuff and reattach the circuit.
Yep. What pressure did your handbag, what pressure did you valve on?
It was on 10, let's put up to 15.
Yeah, still loss of pressure.
Okay.
What could be going on? Like, why 15?
What could be going on?
If you were to bag mask the patient with 15 of pressure and you couldn't do it, what would you do?
I would increase the pressure more.
Great. What do you turn it up to?
Sometimes it goes to 20 or 30. It feels quite high.
At 30, you feel a tightness in the bag.
Yeah.
And then at 30, it loses pressure.
Yeah. Okay. The question then is, at 30 with the tightness of the bag, where we have a circuit, are we producing an end tidal trace?
That small end tidal trace, you got a bit of volume back.
Yeah. Okay. So We are in a tenuous green zone at a APL pressure of 30. I'm going to continue to hand ventilate in that setting and keep an assessment on all of my vital signs, ensuring that we are passing gas, that we have a capnographic trace, that there are no changes to the hemodynamics and oxygenation.
So your volumes are 50 mils,
Yeah.
30 of pressure blow up.
Yeah.
What
Okay.
do you do with that?
So it's very tiny volumes. I'm concerned that there's something maybe obstructing my flow of gas. This could be anywhere in the respiratory tree. I'm going to start by auscultating the lungs.
Oh, good. Lots of loud wheeze around the lungs. Yeah.
Okay. Lots of loud wheeze. I'm going to pass a suction catheter down my endotracheal tube and see if there's any debris, blood secretions in there that can be removed.
Not too much, but there's little specks of blood.
Yeah, okay. So my provisional diagnosis in this setting is significant bronchospasm. We've already called for help. We've already optimized all we can. I'm going to start treating and see if we can improve in the clinical status while hand ventilating the patient. So 12 puffs of salbutamol down the endotracheal tube in my first port of call.
Right. That actually seems to work. What are all the ways you could treat bronchospasm?
Yeah, okay. So in addition to salbutamol, ipratropium 8 puffs down the endotracheal tube is useful. We could give magnesium with doses 2 grams over 10 minutes. We could administer small aliquots of ketamine, so 10 milligrams every 5 minutes. Definitive treatment in this setting is like adrenaline is a very significant choice here. And I'd be, if I'm still bronchospastic after my initial management for salbutamol and ipratropium, I could consider 10 microgram boluses intravenously, Q5 minimally of adrenaline.
Let's say you've actually sorted it out now. You've given a few puffs of Ventolin. That's all that was necessary. It was actually just decent bronchospasm, but everything has absolutely settled now. Let's say everything's going pretty well, but the surgeon's just becoming a bit more rambunctious, let's say, and just really wants hypotensive anesthesia.
Yeah.
It's come to a point where it's a bit uncomfortable. How do you manage that situation?
So this is this is one of the more challenging aspects of anesthesia from time to time, like the non-technical aspects. I'd have a discussion with the surgeon to find out what they're encountering in their surgical field. It sounds like they still have some degree of oozing or bleeding. I hear that their requests for hypotensive anesthesia and sort of gently remind them, but we've had a fairly tenuous and rocky course thus far for this guy, on a private list. We've had hypotension, we've had a bad airway, we've had to reintubate, we've had bronchospasm. He's not an ASA1, he's not an ASA2, and I don't think that he could tolerate a degree of hypotensive anesthesia that the surgeon wants. And so I'd be kind of gently pressing back against those concerns, but in a way that's, in a shared decision manner.
Let's go to the point. So keep going.
I was just saying, to the point where it's all about greater assertiveness, and I identify that we're in a private facility. So if he were to become unwell, intra or post-operatively to a significant level, I'm not sure where we're going to be able to put him.
Sure. You mentioned greater assertiveness. What are other conflict resolving strategies that you know of?
Other conflict resolving strategies. Okay. They can be like reframing the situation to see what the concern is specifically from the surgeon. And again, trying to find solutions that may not be definitively successful, but might improve conditions by small margins. It may be small margins that we need to get through this position. There might be a need to call for someone to help mediate. So maybe another surgeon to come into the room to have a look at the surgical field and see if they can provide an opinion. Maybe I can call for another anaesthetist to come in the room so they can provide another opinion on how best to manage this from an anesthetic point of view. If we're in a position of safety, if the patient is stable, there might be an opportunity to have a quick break for the surgeon just to step away, sit down, clear the head, get some breathing room. And essentially we're all in this together, a team. We're not individual pawns in the field. So we're going to work together. It can be tricky, that I acknowledge.
Hey, good. And that's the end of the Viva.
Oh, thanks, Leo.
Hey, Kim, really, really well done. There's so much good. You've got a very good way of speaking. In fact, you got pretty much all the points that I would want you to say, and you mentioned them in a way that was good with the way you're using language and being thorough. So really well done. How did you feel?
It's good. You're a good examiner, and you're approachable as an examiner, so it feels safe. It's a good case. There are some bits in there like never thought of, and had to get me thinking on my feet, which is a good thing.
Yeah.
So I enjoyed the experience, and it was useful.
So at this point, thanks for everyone watching on YouTube. We're going to put all the formal feedback in the final exam course. So please sign up to that, and there'll be a link at the end of this for that. Beautiful. So we'll see you all again next time. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.